Guwahati, and we would have 4 faculty members, 2 from Apollo Hospital Guwahati itself, Dr. Arvind Kelkar and Dr. Kamal Chetri. We are very dear friends, senior colleagues, and we have Dr. Ashokanand Konar from PLS Hospital, Calcutta, who is a very seasoned examiner who would be helping us in going through these cases. So the format is a little different from what we have been doing. So this time the case presentation will be from the student themselves as they do in the exam. We may interrupt them at any moment, any 4 of us, and ask them some clarification, some questions related to what they have presented. We have about half an hour for each of the 2 cases. So let's start.
The case number 1 would be Dr. Sandeep.
Yes.
So, can you start?
Sure, Kamal.
Hello.
Yes.
Is it audible?
Yeah, you're audible. I can see your first slide.
Okay. Greetings from Apollo Hospital, Guwahati. I would like to thank NBE and Mahesh Goenka sir for giving me opportunity to present a case on this forum. And I will.
So Sandeep, idea in this case is not, you may be knowing the diagnosis. The idea is not how do you match the diagnosis, but what we are looking at today is how do you approach the case as it unfolds itself. All right.
Okay.
So go for the slideshow presentation.
Sir, I have changed slide. It is visible.
All right.
So my patient is Mrs. MDS, 65-year-old housewife, residing at Guwahati, presented with chief complaints of vomiting since 5 days, abdominal pain since 5 days, and she has not passed stool since 3 days. I would because she has significant past history from 6 months, so I would like to start from my HOPI from last 6 months. So she was apparently all right 6 months back. Then she started complaining of fever, which was low-grade fever without chills or rigors, intermittent, once or twice in a week. And she also, along with that, noticed passing hard pellet-like stools once after every second or third day, which was followed by loose watery stool 10 to 15 times a day, small volume, non-bloody, non-false swelling, no aggravating factors. It was not abated by fasting, and the loose stool period that was lasting for 1-2 days. That was the cycle of episodes, and there was no history of any staining or manual evacuation during passing hard stools or any tenesmus or rectal symptoms. It was also irregular bowels, also associated with abdominal pain, which was mild in hypogastric region, intermittent. There were no aggravating factors, and it was not relieved by the defecation. So these symptoms for last starting 6 months back, and they were lasted for 1 month. There was no history of the cough, burning, micturition, headache, or rash. There is no history of chest pain, palpitation, wheezing, or flushing, perineal ulcers, abscess, or itching, joint pain, skin lesion, oral or genital ulcers. No history of jaundice or any jailbreak. She also complained anorexia and weight loss. Her oral intake is reduced to 3/4 of the previous intake. And she consulted a local physician, but symptoms were persistent for 1 month. After that, she went to Hyderabad, and she was diagnosed to have abdominal tuberculosis, and she was started on anti-tuberculosis treatment. After starting of treatment, her abdominal pain, fever, and irregular bowel habits improved, but she had persistent anorexia and weight loss. She complained of almost 9 kg weight loss over next 6 months. This total span of 6 months, and the present complaints she was all right since last 5 days. From last 5 days, she developed vomiting, abdominal pain, and she was not able to pass the stool. This was first was significant past history. So vomiting described it was 3 to 4 times a day, moderate in quantity, greenish or sometimes food containing, occurring 2 to 3 hours after food intake. It was non-bloody or no offensive smell. Abdominal pain was it was associated abdominal pain, mild to moderate in intestine, periumbilical, colic in nature, intermittent, and it was aggravated by food intake, and it was relieved by the vomiting. And since last 3 days, she has not passed stool, and she's passing flatus occasionally. And there were for this last 5 days, there was no history of any fever, abdominal distension, or any hematochezia. History. Past history. She underwent a hysterectomy 30 years back. She is known case of type 2 diabetes mellitus on oral hypoglycemic agents since last 24 years. She is diagnosed hypothyroidism 8 years back, and she has coronary artery disease which was detected 4 years back, for which she underwent PTCA, and there was no past history of tuberculosis. Personal history: married since 45 years. She is housewife, graduated in MA. She is vegetarian. She denied any addiction, and her sleep is normal. And appetite is decreased. I already told that oral intake is 3/4 of the previous oral intake. Family history: no family history of tuberculosis or inflammatory bowel disease. Drug or allergy history: no history of any allergy or complementary and alternative medications. So my summary is 65-year-old housewife, no diabetic, hypothyroid, known case of coronary artery disease, diagnosed case of abdominal tuberculosis with partial clinical improvement after 5 months of ATT, presented with 5 days history of history suggestive of subacute intestinal obstruction of the small bowel.
Okay, can you go back to your first slide? Let's
Okay,
go back to your first slide. Can you go back to your first slide? I have a few questions to ask you and a few comments to make. Yeah, first of all, when you say chief complaint, you are saying that vomiting is 5 days, abdominal pain is 5 days, and not past stool is 3 days. And then in the next slide, you go to a history of 6 months. So I think either you have to be very clear whether you are including that in the present history or you are making that as a past history. If you are saying it's a present history, then you have to talk about 6 months. Now, here you are saying history of present illness is for 6 months. When you talk of chief complaint, you are talking only about 5 days, I think. So I think you have to decide whether you want to present the 6 months history as a present illness. If you have to talk about present illness, then in your first slide, you cannot talk only about 5 days. Okay. Either you put that in a past history if there is a gap between your present symptoms and the past symptoms, or you talk about 6 months history from the very beginning. Do you understand what I'm trying to say?
Yes, sir. I tried. I thought that I would put it in the past history, but it was significant history since 6 months. So I tried to cover.
So I think if you go back to your previous first slide, if you want to include it in your present illness, then why do you want to talk about 5 days? You say 6 months history of fever and altered bowel habits. And then you talk about a recent deterioration in the last 5 days with vomiting, increased abdominal pain, and not passing stool. So I think that would be better rather than just talking about 5 days your chief complaint and then you start the 6 months history. What do you say, Dr. Konar?
I would also agree to that, and I was just going to ask him about the beginning of the history. I mean, if you analyze the history 6 months back, you straight away went to say that, that this patient then went to AIG Hyderabad and diagnosed blah, blah, blah. That's okay. But, you have to analyze the history, what she presented with 6 months back. If you go to the next slide, it shows that the next slide, if you go to the yes, also notice passing hard pellets, like you have to analyze all this.
So can you analyze this altered bowel habit? Will you call it constipation, whether you'll call it diarrhea? What do you want to call this?
That's right. And also whether it is a small bowel kind of diarrhea you think, or do you think it's a large bowel or it doesn't fit into any of this? So how do you analyze the history? Fever, weight loss, and altered bowel habits. All of them needs to be, little bit critically analyzed.
Can you define for us what is acute diarrhea and what is chronic diarrhea?
Acute diarrhea, sir, less than 4 weeks of duration, and more than 4 weeks of duration.
So do you think it's a diarrhea or you think it's a spurious diarrhea?
I think it is spurious because it was alternating for 1 month. The symptoms pattern of the stool.
Okay, I think let's ask you a few questions on this. That when you have a patient with diarrhea, whether it's a spurious diarrhea or true diarrhea, how will you proceed? What will be your steps? First, you decide whether it's acute diarrhea or chronic diarrhea, and then what is your next question which will come to your mind? So, what are the types of diarrhea?
Means it is a secretory, osmotic, or inflammatory. What is the site? Means large bowel or small bowel.
Okay.
And
You would also look at whether it's a functional diarrhea or a
functional
organic.
diarrhea. We have to means.
So,
But
what is
there
the
was
analysis of this particular altered bowel habit in your case? What is the analysis? Let's forget about that a diagnosis of tuberculosis was made. Just
right.
take it away from your mind for the time being. Let's just analyze the case as Dr. Konar said, that you forget about what the diagnosis was made, on what basis it was made. Let's analyze the case as a static. So how do you analyze this altered bowel habit?
sir, because it's associated with
We have lost you all. So the participant can make their comments on the chat box
weight
while
loss.
we are trying to connect back. You put your video off, then maybe your audio will be better. You put your video off for the time being.
Okay, sir.
You just stop your video so that your voice can be heard at least.
Yes, sir.
Yeah. So please analyze the altered bowel habit for us.
Sir, because it was associated with weight loss and anorexia, I will consider it as a any organic cause rather than functional, sir. Because this alteration were there for 1 month, and she had a which was significant and anorexia.
All right, but what is happening here? That there is hard stool being passed for 2 to 3 days, and then there is a diarrhea, isn't it?
Yes.
So how do you explain that? What is the analysis for this altered bowel habit? So you think there is a constipation, there is an intermittent obstruction, and then the obstruction gets relieved, and there is a spurious diarrhea.
Yes, sir. Might be intermittent obstruction. Then after release of obstruction, there is passing of this watery diarrhea, loose stool.
Okay.
But how this obstruction is relieved? I mean, what is the mechanism? Why the patient suddenly had a relief of obstruction and then passes watery stool, again goes back to constipation. So do you mean to think the pathology is in the colon?
Yes,
Or
sir.
in the small bowel? That is the very basic issue, whether this is a small bowel presentation or is it a large bowel presentation. I mean, the spurious diarrhea and all that, if we consider, do you think this can be small bowel or is it? Because later on you are giving us a history suggestive of, as you have said, maybe intestinal obstruction. So whether again that is a large bowel obstruction or is it a small bowel obstruction, the initial presentation.
Initial, sir, I consider it small bowel obstruction, sir.
And this one you said that there is a relief of obstruction and again is passing stool. So is it from the colon or is it from the small bowel?
I think I will consider it terminal part of small bowel or starting with
I think it's difficult to digest that. Something which is causing an obstipation, I mean intermittent obstruction, and then there is suddenly watery stool for 15 times a day. It's unlikely that it will be somewhere in the ileum. What may happen that there is something in the left colon which is getting obstructed, and then when a pressure builds up and the stool and the material collects proximal to the site of stricture, it suddenly gives way, and then the diarrhea starts. I think from this history, my own feeling, and I would want Dr. Kelkar and Dr. Konar also to tell me. What do you think?
From this history, it definitely looks like the left colon or rectosigmoid, things like that, especially when there is this loose watery stools, which may be, again, goes into, there may be a stricture or anatomical problem in the left colon or rectosigmoid. Yes, the left colon maybe, which can explain, but very unlikely to be small intestinal disease. This presentation. Dr. Kelkar, we can't hear you.
Arvind?
Or inflammation in the skin.
So, all right. So one is the location of the lesion, and second is type of the disease. Because there is a fever, you are thinking of some inflammatory pathology, isn't it?
Yes, sir.
All right. Let's move to the next slide. You have said there is no history of straining or manual evacuation or tenesmus or rectal symptoms. So, what do you mean by rectal symptoms?
Sir, urgency, frequency of any, because of inflammation of rectum, the patient will come urgency and frequency.
So you think it's less likely to be the rectal etiology? You think it's proximal to the rectum, isn't it?
Yes.
Now let's analyze this abdominal pain. So you have two types of pain. One is pain which has happened in the initial 6 months, and then you describe another pain in the last 5 days. So can you discuss what's the type of pain, whether it's a visceral pain or a parietal pain, and what is the likely organ which could be involved because of from whatever history you have got? So do you think it's a visceral pain or a parietal pain?
Sir, visceral.
So can you enumerate to me 4 or 5 points which differentiate a visceral pain from a parietal pain?
Parietal pain, intense, sharp and localized. And visceral pain is poorly localized, midline.
What else? One is, you said midline. Why is the visceral pain midline?
Because of innervation of the abdominal organs, it is perceived in the center.
No, but why is it midline? That's the question. Even if the organ is on the side, why is the pain midline? Can you explain that to me? How does the visceral pain is transmitted? Okay, what are the other points? So the entry of the fibers is from both the sides in this case, and that's why it is midline localization. And you said it's visceral pain is usually ill-defined, isn't it? Midline, ill-defined. What else? And visceral pain is not precisely localized, isn't it?
Yes.
And it is usually midline. All right. So what happens to the aggravation by movement? Is the visceral pain aggravated by movements? Is it visceral pain aggravated by movements, or they are not aggravated by movements?
Not aggravated.
Okay. All right. So you think it's a visceral pain?
Yes, sir.
So what is the organ which you think is involved?
According to by the location, I will think colonic origin, sir.
So it's hypogastrium, you said.
Hypogastric.
So you think it's a visceral pain which is arising from the colon, isn't it?
Yes, sir.
I forgot, this is a male patient or a female patient?
Female.
So is there any other organ which can cause pain?
uh, you, the uterus was removed. That's why. The patient.
All right. So you, from your history of bowel disturbances as well as the history of abdominal pain, you are localizing it to the large intestine, isn't it? But you don't
Yes.
think rectum is involved. But you don't think it's rectal is involved, isn't it?
No.
All right. Any question, Dr.
So
Kamal?
how do you fit in the recent development, that is abdominal pain and vomiting? Abdominal pain, vomiting, and the nature of vomiters, as you told us, where do you again put it? I mean, how do you localize the site of lesion?
Can we go to the next slide? Can we go to the next slide? I think let's, yes, this
Yeah.
part. So let's first talk over the pain. We already discussed the pain. You think it's the same site which is causing it?
Relief by vomiting looks like a small intestinal, isn't it? I mean, you have
Yes,
said
sir.
this is mild to moderate, periumbilical, aggravated by food, relieved by vomiting.
Yes,
So
sir.
it points towards the small bowel, isn't it?
Small balls.
And what about the vomiting?
Sir, vomiting was moderate in 3-4 times.
No, how do you analyze? I mean, you have written everything.
And, because of obstruction, sir, vomiting is there.
Now, where is it? Gastric outlet obstruction? Is it gastric outlet obstruction, upper intestine, mid intestine, colon? Where is the obstruction?
I think it is mid, sir, mid small balls.
Why?
That you are talking because it is greenish blue, it's bilious, and it is happening
Yes.
after 2 to 3 hours after the food intake. So you'd think it's somewhere in the small intestine, isn't it?
Small intestine.
And the pain you think is a different type of pain than what it was in the initial illness, or it's the same pain?
Sir, it is different. It was only keen. It is aggravated by food and relieved by vomiting. It is different, sir. Pain is different. Location is also different, slightly upper.
So you think there is an additional pathology somewhere in the small intestine which has possibly come up?
Yes, sir.
All right.
Additional.
We may be all wrong, but let's analyze the history as it is evolving. So I think we have already crossed 25 minutes, so we need to go to the presentation, the clinical presentation. I think the clinical examination.
So, can you ask
Examination.
Yes.
diagnosis at this point and then what is this?
What the total, you need to know the whole story. Don't go by the diagnosis made in Hyderabad. I mean, you cannot just quote that as saying that since it has been made a diagnosis of tuberculosis, so I'll start with tuberculosis. You have to put your money without
Your own analysis
getting
and
into
own
biased by that history.
Can I summarize?
Yes.
Just tell us what you think is the diagnosis from your. What do you think is the diagnosis from your first? What is now?
Sir, diagnosis, I think it is a small subacute intestinal obstruction due to tuberculosis stricture or disease stricture, or because of previous surgery. It may be due to adhesion, and very rarely, but stricture due to intestinal basic disease syndrome.
I have to put tuberculosis first before Crohn's. I think it is Crohn's first. The diagnosis was wrong. Why have you put tuberculosis first?
Sir, because tuberculosis I have put because patient presentation was fever, abdominal pain, and the symptoms, there was improvement after the ETT. Still, the improvement can be seen in the Crohn's disease. But
in this patient, you put Crohn's first or tuberculosis?
So what Dr. Kelkar is asking is that if the patient has not responded much to the treatment, then why not think of Crohn's as the first possibility?
the initial presentation was more likely in favor of tuberculosis, sir. Fever and abdominal pain, more likely in favor of it. Still can occur in Crohn's.
Crohn's also presents like tuberculosis clinically.
Clinically, yes.
Can you differentiate?
Hello, sir.
Can you differentiate between Crohn's disease and tuberculosis? Symptoms and nothing.
More likely symptoms, sir. Completely we can't differentiate, but
So all right, let's give you the point because of the time factor. If it's a tubercular structure, how do you explain the whole natural history of this patient? What may have happened initially, and he received ATT, and now he is presented with intestinal obstruction. What do you
After
think?
5 months. So almost finishing the ATD. So after 5 months, the presentation.
fibrotic stricture can occur, sir, after
disease.
Yes, they tell what is there. How do you think? Why do you think this is happening? If it is tuberculosis.
Sir, after treatment, fibrotic stricture can occur in patient with tuberculosis despite treatment.
But then why was the chronic and now you are having small intestine?
Sir?
Why? How do you explain the colonic type of presentation and now you are having a small intestine?
Randeep, I'm in the webinar, and Dr. Seal is calling.
Or in other way, we can put it, what is the commonest site of tuberculosis in intestine? Commonest, the next and the third, like that. Where do you get the intestinal tuberculosis? Which site in the intestine?
Most commonly, sir, terminal ileocecal wall. Because of initial symptoms, we can be explained if there is a cecum and terminal ileum involvement.
Then
So what are other sites? Less common sites. Okay. So you have kept this possibility. Are there any other possibility you can think of? If I suggest you, it's a diagnosis of eosinophilic gastroenteritis. How do you say that it is not eosinophilic gastroenteritis? Can you explain everything by eosinophilic?
Sir, eosinophilic gastroenteritis, generally their presentation is, they can present like this, but symptoms, when they involve cirrhosis, they present with ascites and edema.
Which is the common type of eosinophilic gastroenteritis can involve the mucosa, muscle, and the serosa. Which is the common type?
Mucosa.
So can this whole thing be because of mucosal involvement now, which has gone to the muscular involvement?
Less likely, sir, but
okay. Now, how do you explain adhesions causing everything?
Sir, because of post
explain fever, which was the presentation. Fever was one of the presentations.
Sir, starting is she is having abdominal tuberculosis that might have improved, but recent symptoms may be due to the adhesions. Apart from TB, that was I was thinking.
Somebody is asking that is it? Do you consider small bowel lymphoma or any? You haven't discussed or you haven't considered any neoplastic disease, which I mean can be. Is there any possibility like lymphoma? Lymphoma, you said that adhesions and stricture related to intestinal Behçet syndrome. You have to consider first the common diseases, no? I mean, before putting rare diagnosis.
Sir, but because of recently she was evaluated. That's why within 6 months malignancy development is less likely. That's why I didn't put malignancy, small bowel lymphoma.
Right. Yes, that is again.
Can it be in immunoproliferative small intestinal disease, which has now gone into florid lymphoma?
Because of that was related to low socioeconomic status previously because of puberty and because of poverty and all the things. But IPSED is decreasing in India.
I don't think that can be a reason for not considering some disease, that it's a disease of poverty, so we'll not consider. That cannot be the reason for not considering the disease. If you tell me it's less common, I can agree with that.
Okay, sir.
Shall we go
Okay,
to?
can we proceed? What? We have only about 5 minutes.
Examination and
Then
Yeah, Kelkar, there are two options. We only either discuss only this case or we quickly finish this and go to the second case. Whatever you say.
yeah, 5
you are the
minutes.
boss.
Just the examination. And whatever you want to
All
ask.
right, so let
Just
me
the
see what
examination.
investigations will you plan at this stage.
Okay.
You have to tell me what investigation you're going to plan.
Investigation, sir. We'll do first because of obstruction. We'll do CT scan, CT abdomen.
I would first say that you should say that I will review all the investigations which have been made, with which the diagnosis of tuberculosis has been made. I think that should be the first thing. You should go to the history and find out on what basis the diagnosis of tuberculosis was made in Hyderabad and whether that diagnosis was foolproof or whether there was some loopholes in that diagnosis. All right. After that, now, because those records are very important now. All right. Now you see that at this moment, first thing you'll do is a CT scan, you said. Will abdominal X-ray help you in this situation?
Abdominal X-ray will also help, sir, because there is the dilatation of ileum or.
So are you going to look for the dilatation of the ileum, or what are you going to look for in the abdominal X-ray?
The distended small bowels, any.
Don't say distended small bowels. This is acute intestinal obstruction. So you're going to look for air fluid levels, isn't it?
So we have this.
Right thing. You should say air fluid levels. You look for. Okay. All right. So CT scan. You said what do we? You will not do any blood tests. You need to do some blood tests.
We can look for inflammation, sir. Routine blood tests, CRP, CBC.
Okay. Then you'll do a CT scan. Do we have a CT scan?
So we have a and that shows there is the maximal diameter extended jejunum is 14 millimeters. There is terminal ileum and cecum colon collapse. No obvious. The jejunum is dilated 14 millimeters and the collapsed terminal ileum and cecum and vital colon.
So you think there's an obstruction in the liver of the ileocecal junction?
Now after knowing CT scan.
Okay. So, all right. So you have a CT scan which shows ileocecal obstruction. What will you do next?
So, first conservatively, if conservative for 48 to 72 hours, then if the obstruction doesn't relieve.
What do you mean by conservative treatment?
Conservative, sir, means I have fluids, antibiotics, and sir, to keep ice tube aspiration and conservative therapy for 48 to 72 hours. If the patient then doesn't improve, then we'll plan for surgery, sir.
Okay. So if the patient improves and the patient opens up, now what will you do?
To revisit the diagnosis and take a biopsy if the initial diagnosis was mistaken for as tuberculosis for Crohn's disease, then we can.
So do you have the previous records in this particular patient as to how the diagnosis of tuberculosis was reached?
Yes, sir. Tuberculosis diagnosis based on histology, sir. There was a definite granuloma, Langerhans giant cells were seen based on biopsy.
Okay. Was AB positive or was gene expert positive?
Sir, TB PCR was positive.
TB PCR was positive. So can you tell us the differential?
Was there any caseation?
Yes, sir.
There was
There was-
caseation in the granuloma.
Based on histology, the crypt architecture was normal, but based upon the histology, they started on ATT, sir.
No, how do you differentiate a Crohn's disease from tuberculosis on histology?
Yes, that's the question.
Histology, sir, tuberculosis is a well-defined granuloma, and that is caseous and confused granuloma. And with Crohn's disease, they have crypt architectural distortion.
No, so one is well defined, second is size.
Sorry.
Caseation, if it is present, it helps, but does not mean that all tuberculosis would have caseation. If it's caseated, then it helps in diagnosis of tuberculosis, isn't it? So even in tuberculosis, there may be non-caseating granulomas.
It will be large granuloma in tuberculosis, small in Crohn's.
So with the PCR being positive and with the type of histology which you have described, so I think it was tuberculosis, no doubt about it. And possibly it is now fibrosis at some stage, which could have caused the stricture formation.
Yes.
Do you agree, Dr. Kelkar?
Yes.
Kamal, any
Yes.
other comments?
But we need to actually scope with the scopy we should do once and see. That's
What was the follow-up? Was that in this patient did the patient undergo
patient got
surgery or?
admitted 2 days ago where he had to repeat colonoscopy on this patient.
So there were a couple of questions on the chat box. Is stool PCR false positive in some cases? Was this stool PCR or was it a histological PCR?
So histological, sir.
So you don't do a stool PCR, you do a histological PCR. Can
Histological
this be
PCR.
left colonic malignancy? Somebody has asked, can it be left colonic malignancy?
Colonic malignancy.
I think with the previous colonoscopic findings being available, this is unlikely
Unlike
that it's a left
Also,
colonic
the
malignancy.
recent CT scan is also against.
But when you talk of the history, I think we should have kept malignancy somewhere in the differential diagnosis.
That's what I was telling, that yes.
Yes. So there was another question is that if it is tuberculosis, how long do you give ATT? 6 months or 9 months?
6 months, sir.
I think there's no doubt
6
about
months,
that.
literature have shown that 6 months is as effective as 9 months. Sir.
Then there's a question lastly, why weight and appetite did not improve in this patient?
So, might be due to the concomitant Crohn's disease also there. That's why.
All right, can there be a component of bacterial overgrowth in this patient?
Yes, possibility, but for yes, can be there.
All right, so I think this is a good case. I don't know whether you have some more slides to present, but we will not go into this any further. We would give the second case some 20-25 minutes.
Okay,
Kamal,
Okay.
should we go to the next case?
Yes, sir, that's fine. Let's go to the next case.
So before he goes, there was a question whether this could be MDR tuberculosis.
MDR tuberculosis, the incidence is less than 10%, sir. Less likely. But patient symptoms was there, sir.
Dr. Mitul present a patient with jaundice.
Start.
Yes, Mitul.
Yes.
Good evening, everyone. I would like to thank NBE for giving us the opportunity to present cases. So my case is Mr. GLR, 32-year-old male, residing at Silchar, Assam, working in animal husbandry department. Came to our hospital on 7th April with a chief complaint of yellow discoloration of eye since 2 months and distension of abdomen since 1.5 months. So history was given by his wife, and he was apparently asymptomatic for 2 months. And since then, his wife noticed yellow discoloration of eye, and it was gradually progressing. And it was initially it was only noticeable in the eyes, but it gradually progressed to the skin, and there was no fluctuation or diurnal variation of jaundice. And there's no history of fever, malaise, prodromal symptoms, vomiting, pain abdomen, itching or clay color stool, blood in vomiting or black stool, altered behavior or sensorium. It was associated with also decreased appetite since last 2 months, and he does not feel like eating anything. And his food intake decreased to 1/4 his normal intake. So 2 weeks
What is
later,
the diurnal variation you have talked about? What is diurnal variation in jaundice?
in Gilbert syndrome, sir, jaundice can be seen in more in the morning hours, fasting hours. So
That is biochemical, but can you actually appreciate that clinically?
no, sir.
Can you appreciate that clinically that there is a difference in the day and night time? All right, carry on.
I think
It said gradually progressive, yeah.
weeks later, he developed a distension of abdomen, which was insidious in onset and gradually progressive. And distension was generalized, and it was not affected by passing flatus or stools, or it was not associated with food intake. And it was associated with swelling with the lip. Initially, it was up to the ankle, and gradually progressed up to the thigh. And he also noticed decreased urine output in terms of less frequency and less amount of urine output. And with this distension, he could walk with difficulty, and he had a difficulty in breathing on walking. And so it is progressive, and now patient is bedridden and required assistance for his daily activity. So there was no history of chest pain, palpitation, no history of fever, cough, or facial puffiness, no history of low stool or in abdomen, no history of fever, cough, or night sweat. So for all these complaints, he went to the local hospital and he was admitted. He had, according to his wife, he had withdrawal symptoms in terms of tremulous and insomnia after 3 to 4 days, and which was subsided by medication. And about 3 liters of yellowish clear fluid was aspirated from his abdomen and was sent for testing. And despite of intervention, patient has persistent distension of abdomen and jaundice. So patient was referred to our hospital. And on admission, our hospital COVID RT-PCR was positive, and he was shifted to COVID 1. In the past history, he has no history of diabetes, hypertension, no history of tuberculosis, coronary artery disease, or COPD, no history of major surgery or blood transfusion, no history of.
All right, we've seen that. Can you go on to the next slide? We have all read it. Go to the next slide.
Okay. So in personal history, he takes normal diet, sleep is normal, and his hepatitis decrease. He's taking alcohol 80 grams per day since 4 years, and he have a history of multiple beer drinking in past 3 months. And last intake was 2 days before admission to the hospital. And he never tried to quit the alcohol. There was no social or legal issue due to alcohol intake, and he occasionally used tobacco. Urine output was decreased, stool was normal, and he is bedridden, and he has difficulty in breathing on standing up. So in summary, 42-year-old man working as animal husbandry assistant, residing at Silchar, with background history of heavy alcohol use since 4 years, came to our hospital with chief complaint of progressive hepatocellular jaundice since 2 months, followed by progressive ascites, swelling of limb, and decreased urine output.
I have an objection to your using the word hepatocellular jaundice in your summary. Don't use the word hepatocellular jaundice. You are just summarizing. So leave the questions to the examiner to ask you whether it is hepatocellular or whether it's a cholestatic jaundice. In the summary, don't include hepatocellular jaundice. You just say progressive jaundice. You agree, Arvind?
Yes.
You agree that in the summary that should not mention about hepatocellular jaundice?
We have told them multiple times, don't use controversial terms in your presentation. Don't use things like constipation. Ask them, is hepatocellular indication problem with the cross-examination?
Without going into the clinical features, clinical profile, can you now analyze your history and tell us whether this jaundice is hepatocellular or cholestatic, whether it is, what is happening? Why did you mention the word hepatocellular here?
Yes, he has no obstructive sign like itching or color stool or pain or fever. So these features go against the obstructive jaundice and more in favor of hepatocellular jaundice.
So you mean absence of cholangitis, absence of pain,
Absence.
and absence of clay-colored stool. Is that what you are saying?
Yes, sir. Absence of itching.
Uh-huh.
Pruritus.
All right. So you think it's a hepatocellular jaundice which is progressive, and then what are the complications which has happened?
Sorry, sir.
And may I add that how do you analyze the history of ascites? As you said that there is a fluid collection and it has been aspirated. So how do you analyze the history of, how do you fit in the history of ascites in this patient?
So he had a jaundice followed by 14 days later he developed ascites. So it's probably decompensation of previously existing chronic liver disease. Or
Chronic liver disease. Why do you say so?
Decompensation of chronic liver disease.
You don't think it is acute hepatitis?
Yeah, severe alcoholic hepatitis also can cause ascites, but it's less common. About in 30% of the cases, we can find ascites in severe alcoholic hepatitis.
Causes might be the underlying liver disease is one, and this is one of the complications of liver disease. You don't think something else has happened, like it is not a malignancy, it is not tuberculosis.
History is not suggestive of malignancy or renal disease or cardiac involvement, chest pain or palpitation or fever. So heart is out.
So
And,
I think that this is ascites is a complication of liver disease.
yes,
What is the liver disease you can think of in this patient from the history? What are the causes of liver disease? I mean, what are the reasons for having this syndrome of ascites and jaundice? What may be the underlying disease in liver?
underlying disease can be chronic liver disease in terms of cirrhosis of liver, compensated. It was compensated till now, and it decompensated to precipitating event, or alcoholic hepatitis.
What is ACLF? Have you heard of the
ACLF,
term
yes, sir.
ACLF?
Yes, sir. We should consider acute chronic liver failure.
Yes. Do you think this patient may qualify for, because you said he was
Yes.
offended, he had ascites, he had jaundice with a background of
Yes.
alcohol. So what is
Yes, sir.
the definition of ACLF?
According to APASL guideline, APASL definition is fitting into the criteria. Jaundice and coagulopathy. Jaundice more than 5 milligram bilirubin and INR more than 1.5, followed by ascites or encephalopathy within 4 weeks after acute insult.
So this fits in, isn't it?
Yes, sir.
Anything else?
Yeah, in acute acute depression causes maybe COVID-19 or ongoing alcohol or other acute viral hepatitis.
COVID-19 can cause ACLF?
Yes, sir. Yes, I have found some case series and reports. It can cause ACLF.
Really, because it can obviously cause jaundice, or it can cause basically rise in transaminases, but whether it can cause ascites and jaundice.
So I think just because we are dealing with COVID-19, we cannot put everything as a first possibility as COVID-19. This patient has been, in any way we can easily explain this even before the COVID-19 period. I think COVID-19 may be just an accidental occurrence in this patient, and we should try to explain by the common things rather than saying that COVID-19 has played a major role into this. So will you really put this as your first possibility, severe alcoholic hepatitis with COVID-19? That means COVID-19 you are saying is an accidental finding, isn't it?
No, I will put first acute chronic failure only, because it is fitting the definition.
What about the third diagnosis as the first diagnosis? Because it's actually decompensation of existing chronic liver disease. And then there may be many precipitants. And as you said, acute on chronic and severe alcoholic hepatitis. What is subacute hepatic failure? Is there any term, do you know? Subacute hepatic failure. Because you said the history is not very long. History is only about 2 months. Started with jaundice. What is this term? Now is it obsolete or is it still valid?
I will not keep it as a subacute liver failure.
Okay, I think
Okay, how can you proceed now? We have 10 minutes left. So how will you proceed?
So we first will confirm the diagnosis for the
How
By-
will you confirm the diagnosis?
by the laboratory imaging laboratory that we will send red blood count, CRP, and total liver function test, and urine. Especially we will look for urinary protein to rule out whether any renal cause involved in the ascites, and ascitic fluid analysis that we will see the total count SAG ratio by albumin and ascitic fluid albumin.
What is SAG ratio? I thought SAG is a gradient.
SAG gradient, sorry. Serum albumin ascitic gradient.
Okay.
Any viral marker you want to do? Viral markers, your written.
Viral markers, yes. Viral markers we will do hepatitis B, hepatitis C, anti-HIV, anti-HCV, viral markers.
No. You clarify a little bit. You are putting all of them. You said hepatitis B. What test will you do for hepatitis B?
And HB SAG, surface.
So if you do an HbAg and if it is negative, do you rule out acute viral hepatitis?
No, sir, no. Because latent, in that case, we have to do a total core antibody, total core antibody to latent hepatitis B.
What will be the role for anti-HBC IgM in this situation?
It will rule out acute hepatitis B.
Okay, so you should do HbAg and you should do anti-HBC IgM. You said you will do anti-HEV. What HEV?
Hepatitis E antibody.
What antibody?
Anti-HE. IgM.
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 What about hepatitis A?
That also IgM.
What about hepatitis C?
Anti-HCV IgM.
Anti-HCV IgM. That's very interesting.
IgG.
Okay, is there any stigma of, chronic liver disease or of alcoholism in this patient?
No, sir.
There's
No,
no stigma of chronic liver disease. What have you looked for?
In the examination, in stigma of alcoholism, parotid enlargement, and contracture is not present, and stigma of chronic liver disease like gynecomastia, loss of axillary hair, spider nevi, testicular.
There was no. Have you looked for any flap? You said the patient was confused at times, he cannot remember things. So have you looked for any hepatic flap, as they call it?
All right, can I ask you one question? That what is the age of the patient? What is the age of the patient? I missed out.
34, I think.
Hello?
What is the age of the patient?
34. See, just because he is taking alcohol, should we not consider some other possibility like Wilson's disease?
Yes, sir. We can consider Wilson also.
Why should you bother about these uncommon diseases like Wilson's? because they have a definite treatment to offer. All right. So even if they are rare, you must consider these possibilities because there is a specific treatment which has to be started. All right.
In family history, there was no specific family history or consanguineous marriage, so I have to rule out.
No, you can't rule out. You can't rule out Wilson's disease because there's no family history. You can't say that.
Okay.
Wilson's disease should be
If it
considered.
is positive, then there you should be more suspicious, but you straight away cannot rule it.
Okay.
There's no
Yes.
still should investigate.
All right. So what will be the further investigations? What further investigations will you do?
For the image, we will do ultrasound with Doppler. Ultrasound abdomen with.
How will the Doppler help you?
It will show if there is any thrombosis in the portal, or it will show reversal of the flow. It can give idea about the portal hypertension by looking at the portal diameter.
All right. So one, you'll do an ultrasound with the Doppler. Then you've already investigated for virus, Wilson's, autoimmune. Fine.
He has done the ascitic fluid study also.
You have done the ascitic fluid study.
What else can
Did you look for
really
sepsis? Did you
decompensate?
look for sepsis elsewhere?
Yeah, SBP, do you think you should look for?
I told that total count in for infection elsewhere in the chest or urine or any precipitating.
You should send a full septic profile of this patient because sepsis may be one of the factors which may be causing the acute component. All right.
Yes.
So do we have more data on this patient? Kamal, do we have some data to discuss?
He's been with us for a long time. He was in COVID, then he became negative. Then he's back with back to the ward after the COVID being negative. Then he is still with us. He has renal dysfunction that is improving. Now he has developed right hydrothorax, which has been repeatedly tapped. And for that, he had respiratory distress. He was also given toliprecin and albumin during the hospital stay because of the renal dysfunction. The renal parameters have slightly improved, and after tapping and albumin supplementation, his right hydrothorax is getting controlled.
So if the right hydrothorax does not respond to treatment and the patient improves, then what are the options you have? If the right hydrothorax continues to be a problem, what are the options you have?
We can put on tips we can have offer.
So will you do some tests before doing the tips, or are you okay doing tips without any further test?
We can look for anatomy of the vessels.
How do you look for the anatomy of the vessels? You mean splenoportal axis?
Yes, sir.
So what will you do? You are okay with the Doppler, or whether you'll do a CT SPV?
We can consider.
And also look at hepatic veins. Hepatic veins are also important.
So how do you know that this is hepatic hydrothorax? Can you do some radionuclide studies?
First of all, we'll look for SPEC like serum pleural fluid albumin gradient, so similar like. So if it is more than 1.1, then we can consider if there's a hepatic. Look for any other infections. Pleural fluid analysis.
Okay, I think we missed out. But what is the treatment of alcoholic hepatitis? What are the specific treatment you can offer to this person?
In severe alcoholic hepatitis, according to if the MADRS discrimination function is more than 32, and if there is no signs of infection or bleeding or renal failure, then we can offer steroids, prednisolone 40 mg per day.
So how will you follow these patients? If you start them on steroid, how will you follow this patient?
After 7 days, we will look for Lilly score, and if it is more than 0.45, It is if it is for
Are there any studies where the limit score has been modified and seen at less than 7 days?
I am not aware of, sir. Any study.
So now there are studies which has looked at the 3 days value also, because you need to sometimes decide for early transplant in these patients.
And is there any
What are the other options?
above which you cannot really give steroids? Say MDF, you said 32. If it is 96, what would you do? Would you give steroids? Is there any cutoff above which you really should not go for steroids? And as Dr. Goenka said, you should consider doing an early transplant. What is the cutoff of MDF? Is there anything called?
More than 72?
It's about 56 actually. 56, it is above 56. Then you should not use steroids. Because there are
So can you just enumerate the other modalities of treatment other than steroids? 1, 2, 3.
Other than nutrition, then newer modalities GM monocyte colony stimulating factors.
All right, that's one. Number 2.
Then
What about plasmapheresis? What about plasmapheresis?
Yes, albumin dialysis with Mars and liver transplantation.
What about fecal microbiota transplantation?
Yes, it's being given fecal microbiota.
So see, you have to come out fast when somebody asking you questions. You cannot be asking you and giving you leads. So you have to quickly say the alternative modalities are growth factors with plasmapheresis and fecal microbiota transplantation. All right.
Yes.
Is there any role for N-Acetylcysteine?
Yes, no role, sir.
All right. So I think we have crossed the time. Dr. Konar, Kamal, Dr. Arvind, any last minute comments?
No, I think this was a good exercise for them. You have to keep and think on your feet. The problem is they know and they cannot answer thinking in that short time. I think that is the lesson that you have to do. Practice more and more.
I think they practice. See, fortunately for us in gastroenterology, there are hardly 8 to 10 types of cases which you can get in your exam. You can put them on fingers that there are about 8 or 10 types of cases which you will get: abdominal pain, diarrhea, jaundice, lump. These are the colitis. These are the usual cases which you get. So there are hardly 8 or 10 cases. All right. So should we call it a day, Dr. Konar?
I think so. I think we had a nice time, but I think they need more practice, isn't it, Arvind? Just to come up with all the answers.
Yes.
1, 2, 3,
They have to be able to think. They have to be able to think immediately. It's not on the tip of their tongue. The whole problem. You have to have it.
Sure, they knew about the case from the morning, if not yesterday. So they should be ready with all the possible questions. No?
Yes.
But they were reasonably good, I would say. That the only thing is that fast reaction. So
Fast
need to practice. I'm happy today we had almost about 235 participants for this DNB online program. So thank you, Mr. Singh. And we'll wind up today and meet again next Monday at 6 o'clock. I will send you the details in a day or two. Mr. Singh.
Thank you very much, Dr. Sandeep and Dr. Metal for the presentation, and thank you very much, Dr. Konkar, Dr. Konar, Dr. Goenka, Dr. Shetty, and Dr. Kelko for joining us. Thank you, students, for joining us.
Thank you.
Thank you.
Thank you.